We're blessed to have Ben Roberts here, a retina specialist who comes to us from Alabama. Ben has a Heart for Missions in Kenya and is going to speak about retinal urgencies and what was it, biblical
orality storytelling.
Okay.
Yeah, so
Great.
good.
Thanks for coming.
Maybe we'll keep Mark in the room for expertise on some of these retinal issues. Fantastic talks, by the way, by him. So, good. The title of this talk, Retinal Emergencies and Urgencies for the Comprehensive Ophthalmologist. And I had the privilege of serving as a comprehensive ophthalmologist for a couple of decades in Kenya. So all of you that do comprehensive ophthalmology, thank you. Fantastic. For the past year, I've been serving as just a retina surgeon in Alabama. I've enjoyed that as well, but I do miss the comprehensive aspect of ophthalmology. I have no financial disclosures, and I'm going to look at these 9 conditions. Some I've labeled under emergencies and some under retinal urgencies. It's not going to be a comprehensive talk on any of these, but the main goal is geared toward comprehensive ophthalmology, when to refer, maybe some pearls about diagnosis, and those of you that have kind of wider scopes of practice, some of the things that you can do without referring. So let's look at these 4 conditions that I've put under retinal emergencies, the first one being the dreaded endophthalmitis. So you do cataract surgery on a 75-year-old male. Patient comes in 5 days later, and this is what they look like. It's something that we all dread with cataract surgery. We tell patients the complications of cataract surgery is very low, but it's not zero, right? So endophthalmitis is a possibility. This patient came in, had a vision of 20/70. What are you going to do? Well, I put this under emergencies because the sooner you can get this patient to a place for treatment, the better. And if you're able to treat this patient yourself with intravitreal injections, great. If not, then refer to someone that does it. We lean heavily upon the endophthalmitis vitrectomy study, which is an older study in the early 90s, but still provides very useful information for patients with infections. And in summary, kind of the bottom line with endophthalmitis is if the vision in the patient is light perception, then they fared better with doing a vitrectomy, doing an immediate vitrectomy. They had a 3-fold chance of recovering 20/40 vision with a vitrectomy. Those with hand motion or better vision do just as well with a tap and inject, placing antibiotics. Typically, these days we use vancomycin, ceftazidime, and sometimes a steroid agent, dexamethasone. Other things you consider, depending on where you are, if you don't have a retina specialist that's in the area, and the referral is going to be a long time before they get to a retina specialist, or at least many, many hours. If you have the ability to go ahead and inject antibiotics, I would say go ahead and do that if you're comfortable doing that. In this day and age, I know a lot of comprehensive ophthalmologists are used to doing intravitreal injections of anti-VEGF. So if you have the ability to have these antibiotics and your suspicion is very high, like in that picture that we saw, then I would say go ahead and do that. Some people are a bit apprehensive to do a vitreous tap. Even us as retina specialists, sometimes we're not successful in getting a good sample with a vitreous tap. You can also consider an AC tap. I think all of us are comfortable doing that. It's technically easier, but the yield is typically not as good. Let's keep going. Case number 2 is an 81-year-old female, 6 days after intravitreal bevacizumab, comes in with a hypopyon and vision of 2400. So the endophthalmitis vitrectomy study didn't really have any of these cases because this was before the intravitreal era, before we were injecting medicines into the eye. But we still kind of rely upon that information in how we treat this. So 2400 vision, if this patient came into my office, then I would first do a B scan, confirm that there is vitritis, that this is an endophthalmitis, and then I would inject them as if they were infected with vancomycin, ceftazidime, and I would follow them very closely, and I wouldn't hesitate to take them for vitrectomy if the vision were to get worse. Now let's look at this case. 76-year-old female, post-op day 1, status post-phaco. They come into your office. The vision's not so bad, 20/50, but there's corneal edema, limbus to limbus corneal edema, And the key is that when a B scan is done, there's no vitritis. So what is this? This is TAS, toxic anterior segment syndrome. And as you all know, this can be from bacterial endotoxins or particulate contaminants in the BSS, or if you have some problem with your sterilization, you can get this inflammatory condition. They usually respond very well to topical steroids given hourly. So that's how I would approach this patient. If they were to get worse or the exam changed, then you could consider injecting antibiotics as if it was infectious. Let's keep moving. Case number 4 is a 72-year-old female that had uncomplicated phaco surgery 1 week ago. They come in with a vision of light perception. So if you look at the EVS study, someone comes in with light perception, they fare better with a vitrectomy. And that's what I would recommend in this patient. This patient, as you note, has a hypopyon. You can see the eye well. There is some vitreous debris in the back of the eye. If you were to do a B scan, then you would see dense vitritis in this patient as well. So this patient needs referring as soon as possible for vitrectomy. Now, if you have the ability to give antibiotics and it's going to be a 12-hour or a 20-hour delay before they can have a vitrectomy, I would recommend go ahead and giving the intravitreal antibiotics, even if they're going to go for a vitrectomy within 24 hours. And this is just a short video, maybe if I can, there we go, of standard 25 gauge vitrectomy. Sometimes it's hard to visualize the trocar, so we'll stick a light pipe through the infusion port. Now we're doing a pure sample. This is sped up, by the way. Doing a pure sample for our vitreous biopsy. And through his paracentesis, try to clear out the anterior chamber by washing out any fibrin. Sometimes you can do that just with AC cannula and BSS. Other times you have to use forceps to manually peel membranes that are overlying the pupil. So we try to clear the anterior segment first, and then take our attention to the back of the eye. As you can see, there's a dense vitritis. Now, if possible, it's very helpful if you can induce CVD, but I always tell our fellows that only do the amount of vitrectomy that you can safely do, because getting a break in the retina, causing a retinal break, is disastrous in this situation. But if you can elevate the hyaloid, it's useful. And then at the end of the case, you're simply going to inject your antibiotics, your vancomycin, ceftazidime, and or dexamethasone. And that's what we're doing here at the end of the case. Remove our trocars, and typically we'll also give some subconjunctival antibiotic and steroid at the end of the case. Now, these patients often look worse on post-op day 1, but then they begin improving after that. All right, case number 5. 4-year-old helping dad using a paint scraper, and they come in looking like this. All of us as residents and in practice see these unfortunate cases. This is a corneal laceration, and by history, it was a paint scraper, so a large object, so you wouldn't expect any intraocular foreign body, but if there's any suspicion, then you need to check for that, and you can do that by doing a CT scan, or in the third world, orbital x-ray works very well for looking for metallic and foreign bodies, and it's a cheap way of doing that. This patient only had a corneal laceration. That can be repaired. The lens was not violated, and then the question comes postoperatively, how long do you leave the sutures, and what do you do to help rehabilitate their vision? I typically would leave the sutures 4 to 6 weeks before removing them, unless any of them are loose. If they're loose, to go ahead and take them out because they're not helping at all. All right, next case, 28-year-old male presenting after hammering metal at work. You've got to be highly suspicious for an intraocular foreign body with this history. They come in with pretty good vision of 20/60. The lens looks pretty clear, but on posterior exam, you see this metallic foreign body lodged in the infratemporal retina. So this is just there we go, a video of that case. Sometimes intraocular foreign bodies can be hidden. The initial goal is to close whatever entry wound that you have. And in this case, it was a corneal wound near the limbus, so that's closed just with 10-0 nylon sutures. And then we will turn our attention to the back of the eye for a standard 25-gauge vitrectomy. You can see the impact site here where there's blood, and then the metallic foreign body, that's the impact site. The metallic foreign body is resting right there. So we did a good vitrectomy and then used laser to help laser both the impact site and the area where the metallic foreign body was to help minimize risk of retinal detachment. After that is lasered, we have to turn our attention to removing the intraocular foreign body. So we removed the trocar and extended the sclerotomy site, and this is a magnet, that 20-gauge magnet that is very helpful with these metallic foreign bodies that you can put into the vitreous cavity. The metallic foreign body just quickly attaches to the magnet, and then you try to center the foreign body on that magnet so that it will come out of this sclerotomy that you have enlarged and without complications. And there's the foreign body there. And then you close your wounds. And this is one of our fellows. They enjoy their victories, so they wanted to celebrate that as well. Okay. This is a 56-year-old. We had very good comments by Mark recently on acute retinal necrosis, and that's what this case is. It's for a retina specialist, for me, it's a very dreaded disease. I don't like this disease because the outcomes often are very poor. But the patient came in with 20/70 vision, 56-year-old female, had progressive vision decline and floaters, and came in with a picture like that. So diagnosis, I think he spoke to this. One of the first things that we recommend doing is getting a sample of fluid from the anterior chamber and sending for PCR analysis, looking for viral HSV, VZV, CMV, and then if you have any concern for infectious toxo as well. Acute retinal necrosis, again, it's this peripheral retinal whitening that marches toward the macula. A third of the patients can have bilateral disease. You'll remember the acronym BARN, bilateral acute retinal necrosis, and it usually affects healthy immunocompetent adults. As I mentioned, you do a viral PCR of the aqueous or the vitreous, and if you're pretty confident that it's herpetic, then we'll treat with phoscoronet. Sometimes you can treat with ganciclovir until you get a diagnosis, and that's usually 2 injections per week, so every 2 to 3 days for a total of at least 5 injections, and then put them on Valtrex or valacyclovir, 2 grams TID, and you can consider using steroids, oral steroids as well. As he mentioned in the earlier talk, a large percentage of I was excited to see that he mentioned about doing early vitrectomy, you have a lot less risk of retinal detachment, but that's the dreaded complication in this disease is retinal detachment, and it can occur. All right, let's keep moving. Case number 8, 54-year-old female comes in with high pressure of 52, vision of 2400. Slit lamp exam, what do they have? Have vessels, have iris neovascularization, blocking the drainage pathway. This is neovascular glaucoma. So you want to think about the typical etiologies for that. Is this patient diabetic? Do they have proliferative diabetic retinopathy? Have they had a vein occlusion? Or do they have any carotid disease like ocular ischemic syndrome? Anything that would cause you to have iris neovascularization. And then you want to manage it by lowering the pressure with topical drops. You can use oral medication if it's safe to do so. And if your view is good, then you need to start treating to get rid of these blood vessels. You can do that by putting PRP laser treatment. You can also do that more acutely by giving intravitreal Avastin. One little pearl about doing that, in these patients, the pressure is already high. So injecting into the vitreous cavity, the pressure is going to go even higher. So one of the things I like to do is just use a 30-gauge needle and inject your bevacizumab or whatever your choice of medication is into the anterior chamber and have an assistant immediately after you inject it to withdraw fluid from the anterior chamber to lower the pressure. So in theory, you're going to be removing some of the medicine you just put into the eye, but you're not removing it all, and it's very effective in lowering the pressure at the same time. All right, let's keep going. Next case is very similar. Patient comes in with high pressure of 55, but their vision is no light perception. Changes things a little bit. This is now a blind, painful eye. and your goal for treatment is to preserve the eye, make the eye more comfortable. So people are going to be very hesitant to operate on a blind eye. Our glaucoma colleagues usually don't want to do that. So you can use your glaucoma medications to help lower the pressure. If you have a view, again, laser treatment, you can inject safely with your anti-VEGF medication. And then often our glaucoma colleagues prefer to do something like a diode laser, which is not very, it's not like a true surgery, but a laser that can help reduce the pressure. This is just a fun picture from several years ago in our practice. I don't know how well it shows up, but the one on the left, just florid iris neovascularization, and avastin was injected into the anterior chamber, and this next picture is 24 hours later. It just melts it and goes away. Now, even though the INV has disappeared, the pressure can still be elevated. Just because the blood vessels go away doesn't mean the pressure is going to be solved, but it's a step in the right direction, and so you need to do that. Let's move on to urgencies. One of these actually maybe should be in the emergent category, but we'll look at some of these categories or some of these diseases here quickly. Okay. Patient comes in with great vision, 20/20, but they're complaining of a shadow in their peripheral vision. And when you examine them, they have a large horseshoe retinal tear with a superior retinal detachment, a MAC-on retinal detachment, macula sparing. And OCT is very helpful for that. Even as a retina specialist, sometimes you look and say, is there fluid in the macula? Is there not? Get an OCT. It will show you if there's fluid in the macula, and that will help make that decision. But surgical referral and surgical approach, you want to get this person to a retina specialist as soon as possible. If they came into our practice, I would operate the same day or, if possible, within 24 hours. So, okay, next patient comes in with hand motion vision, has a PVD, and their retinal break is inferior at 6 o'clock. Okay, PVD, retinal break is inferior. This OCT clearly shows that it's a macula involving retinal detachment with fluid under the retina. Again, timing of referral is not as urgent because the macula is always involved. Historically, people say, well, you need to operate within 1 week. Some of the more recent studies show if you can go to surgery within the first 5 days, then the visual outcomes are just as good. So in our practice, if someone comes in with a macula involving retinal detachment, we try to go to surgery within the first 5 days. And I always, think, what would I do if this was my father? My father said, yesterday I had good vision, and this morning my vision became poor. That macula just became involved. And the sooner you can take that patient, the better. But it's not as urgent as a macula-sparing retinal detachment. So what would you do in this case? Break at 6 o'clock. I would treat this by putting a scleral buckle and then doing a vitrectomy and either leaving them with a gas or silicone oil. Next patient, 30-year-old phakic female, good vision, no PVD. If you look at the color picture, you see there's a small retinal break with fluid extending into the just to the edge of the macula, but it's not underneath the fovea. This is a great patient for a scleral buckle only. You can do a scleral buckle and drain externally and never have to do a vitrectomy. It works. The retina will go back into place, and you've not increased the risk of a cataract. You've just maybe changed the refraction just slightly because of the scleral buckle. Okay. 72-year-old comes in with flashes and floaters. You guys see these patients all the time. This picture shows a typical Weiss ring as the vitreous gel has separated. When do you follow up? When do you see these patients again? Well, first thing you want to do is make sure you do a good exam and make sure there's not a retinal tear. That's what you're looking for. Is there a retinal tear when that vitreous gel has separated? And if you're confident with your exam that there's no retinal tear, then you can treat these yourself. You don't have to send them to a retina specialist. One thing I would say, always look for Schaefer's sign or the pigment behind the lens. If a patient comes into my office and I see some pigment behind the lens on the anterior segment exam, and then I go to the posterior exam and I'm not seeing a tear, I'm going to look and look and look because there probably is a tear. So if you see pigment, if you see Schaefer's sign, you're not seeing a tear, maybe you want to refer them to have a retina specialist take a look as well. Next case, 68-year-old with flashes and floaters. Again, they have a PVD, but what else do they have? They have blood in the eye. So we call this a hemorrhagic posterior vitreous detachment. If there's blood in the eye, that increases the risk that there's a retinal tear dramatically. Studies range between 50 and 70% that there's a retinal tear. So if you see blood in the eye, there's likely a tear. You got to find that tear. And there could be more than one tear. So you need to be confident with your peripheral scleral depressed exam when you're managing these patients. And if you can comfortably say, I can see all the retina, if you see a tear and can treat it. If not, refer to retina to get laser around that tear. And if you see one tear, but there's blood interfering with, say, the inferior retina, and you can't really visualize the inferior retina, this is a reason to refer so that that patient can go to surgery. So hemorrhagic PVD, if I'm not able to see all the retina, I recommend going to surgery to do a vitrectomy, finding the tear and treating it appropriately. This is just a picture of a patient that came in with a clear horseshoe retinal tear that was treated effectively, and the question is, when do you see them back? Typically, I would look back in a week to make sure the laser looks good, and then about 1 month after that. All right, let's keep moving on here. This is a 74-year-old that comes in with sudden painless vision loss. I'm not showing you a picture of the retina, but what I am showing you is an OCT, and what do you notice? This, in the right eye, this hyperreflectivity on the OCT and the inner retinal layers. Very typical for an artery occlusion. So you may look in the eye, you may not see the typical cherry red spot or retinal whitening in some of these patients, but if you do an OCT and you see this hyperreflectivity, that patient has had an artery occlusion. So let me back up here for this briefly. If you see this patient in your office, what is the next step of treatment? The next step of treatment is to get them to an ER where there's a stroke center. Okay, that patient deserves a full workup for a stroke where they evaluate them systemically by doing a CT or MRI, doing an echo of their heart, looking at their carotid arteries, and doing the appropriate lab work looking for any other stroke, because these patients have a higher risk of having had a stroke. I saw a patient just 2 months ago that came in with this typical picture, and I looked in the eye. I happened to saw multiple little emboli in their arterial system, and then I asked them a few questions. Are you having any weakness? And they said, well, I had trouble signing in this morning at the front desk, and I didn't know. So they were actively having a stroke, so get them to a stroke center as soon as possible. Then the instructions after their stroke workup and treatment is to follow up with you in 4 to 6 weeks, and you need to follow them looking for the rare event of neovascular glaucoma, which can occur even after artery occlusion. I want to move quickly, just a couple more cases here. This patient comes in, 79-year-old with decreased vision. If you look at their color photograph, you see retinal hemorrhages, all 4 quadrants, dilated tortuous vessels. This patient has a central retinal vein occlusion. You can treat them, but if you're referring to them, the time of referral would be 1 to 2 weeks. It's not as emergent as some of these other conditions. And what are we looking for when we're treating and following? Well, the OCT demonstrates this patient has reduced vision because of cystoid macular edema, so that needs to be addressed and treated, and typically we treat that with your anti-VEGF of choice. And these patients are monitored for many months looking for signs of neovascular glaucoma. And just one pearl always to remember, to look in the anterior chamber and to use gonioscopy as well, looking in the angle. Sometimes you will not see any iris neovascularization just with your slit lamp beam, but if you use a gonio lens, you can see it in the angle. So always be aware of that and be careful to do that as well. And this may be our last case here. 77-year-old comes in, Caucasian male, let's call them, and then they have subretinal hemorrhage and subretinal fluid, a disease that I didn't see much of in Kenya for 2 decades, but as you know, in America, it's very common, and that's macular degeneration. This patient has wet macular degeneration. Some of you are comfortable in treating that. It's so prevalent that you treat it, but if you do referring them within 1 to 2 weeks for treatment is appropriate. And then If they come in with a sudden drop in vision, and you see this clinical picture, they have maybe known macular degeneration, but here they have a large area of subretinal hemorrhage. That's a little more urgent if you can refer to a retina specialist, because in some cases, some patients, we will recommend going for vitrectomy and pneumatic displacement. And I just have a quick video of how that can be effective in improving their vision. So some retina specialists would say, no, just treat this with anti-VEGF, and that's definitely an appropriate treatment. But this can be effective if you catch these patients within the first week of their bleed. So a core vitrectomy has been done, and then using a Dewan's needle, which is a 41 gauge needle, you penetrate the area where the subretinal hemorrhage is, and inject a bleb of subretinal TPA, tissue plasminogen activator. And you'll see in just a minute, if we can get that bleb started. Videos show reality. You know, it's not all just or let me say, this is our fellow doing this, right? So I was instructing our fellow doing this now. But you see this bleb forming around the blood, and we injected this medicine in the inferior macula so that the bleb would appear more inferiorly. And then when you do the air fluid exchange, now you have this air bubble in the eye, and it helps to push or to squeegee that blood out of the macula, and that's the goal. You're not getting rid of the blood. It's still going to be under the retina, but if you can get it out of the macula, then their vision will improve. And do an air fluid exchange and then follow them. And I'll go briefly. This is a different patient, but similar diagnosis. 1 month after pneumatic displacement, the blood's been pushed out of the macula, and it can dramatically improve their vision. So thank you very much.